Ah, tá. Deixa eu aceitar no meu aqui também. Podemos então, né? Okay, so we're starting another immunowebinars today, and it is a great pleasure of mine to have here with us Dr. Elaine Sobral da Costa. She is a CNPq researcher, productivity 2, and she is actually like a doctor, 2 times doctor. She graduated from the medical school here at UFRJ in 1996 and followed with her residency at pediatrics. She specialized in pediatric hematology and entered and started her master's in clinical medicine with Dr. Marcelo Gardan Poirot and Dr. Adriana Bonomo, finishing in 2003, the year that she entered at the Institute of Pediatrics and Child Care, Martagão Gesteira, IPPMG at UFRJ, as a pediatric oncohematologist. After that, she did her PhD in medicine at still here in our house at UFRJ with Dr. Nelson Spector, where she was able to go to Salamanca for a few years and work there under the supervision of Dr. Alberto Orfal at the Centro de Investigación del Cáncer in Spain, in Salamanca, where she's still a visiting researcher since 2006. She has developed new analytical methods for diagnosis and monitoring of malignant tumors by flow cytometry, and she has participated in several patent depositions. Besides all the work that she has done, she has over 60 publications in this general area. She's a member of the EuroFlow, the European Flow Cytometry Consortium, and a coordinator of the Nucleus of Research on Child and Teenager Health at UFRJ. She has written more than 12 book chapters, and she has 5 patents deposited. And doing all that, she has worked very hardly in human resources, having today 4 undergraduate students, 6 master students, 3 doctor students, and 2 PhD postdocs in her laboratory here next to our building. So it is a great pleasure to have you here, Elaine. Thank you again for accepting our invitation. And we'll stop for questions at the end. Thank you.
Thank you, Miriam. Miriam was my friend in the lab in my master, so we met a long time ago. So we will talk about the use of flow cytometry for pediatric tumors diagnosis. So it's a little bit more applicated investigation than maybe you normally talk about, but eu tinha testado, eu juro. So pediatric cancer is the first cause of death in developed countries, and also in Brazil, we have the first cause of death by disease over 5 years or 5 years old. So we have in Brazil 8,000 of new cases by year. So it's a great instance. It's not a rare disease. And the biggest problem is the time to diagnosis. So we spend more than 1 month in most of cases to have a diagnosis. So most of pediatric tumors have embryonic origin. So they have fast growth because of this. And most of them simulate benign conditions of children. So the suspicion of cancer can be delayed. And after that, after the medical suspicion, laboratory study imagines we have to do a surgical biopsy, and the diagnosis is based mostly in histopathology and immunohistochemistry. Most of pediatric tumors are different than adult tumors. So the several ones maybe you are not familiar with, as neuroblastoma, Wilms tumor, bone tumors as Ewing sarcoma, osteosarcoma, rhabdomyosarcoma, retinoblastoma. They are several tumors that we don't found in adults. In adolescents, we have also germ cell tumors from testicles or ovarian in that list, and some tumors that adults have as melanoma. So the most frequent are the hematologic tumors, leukemias and lymphomas, but they are very well studied by flow cytometry. Flow cytometry is usual in routine labs to diagnosis of hematological disease, except Hodgkin lymphoma. The others are well diagnosed by flow. And the second one, the brain tumors, we don't have access to samples now, so we are dedicated to the other non-hematopoietic tumors and also the hematopoietic, but the non-hematopoietic is the new thing. So the conventional diagnosis in pediatric solid tumors is done by histology, histopathology, and I'm not a pathologist, but they are quite similar by morphology, and the pathologists say that it's a blue small round cells tumor. And they need, it's because the embryonic origin, that the morphology is quite similar, and they need to perform immunohistochemistry to the final diagnosis. So how it is done? First, they see the morphology. So they stain at, for instance, CD45 to see that's hematopoietic or not, CD20 for B cells, CD3 for T cells. These three antigens are negative, so they suspect, by the site of the tumor or so on, it could be a neuroblastoma. So they perform NB40 or GD2 or so on, and they do it by rounds. Each round of immunohistochemistry takes 3 days to have the stain. So the minimum time of diagnosis could be 7 days, but normally it's not common to have the diagnosis before 15 days. And we have a condition that have fast growth. So many times as a pediatrician, I have a baby with abdominal mass, and the baby was biopsied, but we don't have the result. And it comprimes the breath, and we have to start the chemotherapy without the diagnosis. It was not 1 time and 2 times to cure it. So it was my motivation to start this study. Our motivation, we have a team. So comparing the techniques, we have 15 days as a median time as to the diagnosis, and flow cytometry could be it in few hours. We normally each stain is one marker by stain by immunohistochemistry. We can stain several markers in each aliquot, aliquot of sample by flow. In contrast, we maintain the tissue organization by histopathology, and flow cytometry. We have to disaggregate the cells, individualizate cells. And we have very well established criteria to do the diagnosis by histopathology, and flow cytometry is ongoing. The experience is much higher by histopathology, but in flow cytometry, we have much less experience, but we are working also in automated analysis as a support tool to take decision. So first papers are very old, 2004. They describe in bone marrow neuroblastoma cells that express highly CD56 without CD45, with expression of CD9, CD81. And in that time, we had 3 papers when we started this study. 3 papers describing pediatric solid tumors by flow in few samples. And we decided in 2009 to start this study. And in 2013, we described 52 samples with 40 markers, more or less. And here is an example of that time. It's rhabdomyosarcoma with low expression of CD56 and expressing myogenin and myode-D1 without CD9, CD81, without CD99. So we resaved the sample, and we performed the mechanical dissociation. We have tried to do it with enzymes, but they destroyed the antigens. They destroyed including CD45, so we could not properly separate the immune cells than tumor cells. So it's hard to do with enzymes. So we have to do mechanical dissociation with 2 needles. Some services do it with scissors. So we process cells in a suspension freshly. So it's a kind of limited step because some surgeries during many hours. So we have the sample at final of afternoon, and we have to process it at night. It's could be nice to preserve cells, but until now we don't have some efficient to do this characterization. So we do the flow, we stored sample to the fish, and we freeze in also viable cells. And we can integrate flow cytometry data, ploidy information, and fish information. So it was a difficult case we have because we have 3 cell populations. We have one population with CD99 expression that's typical of Ewing sarcoma, but the other population with myogenin, that's a protein expressed in rhabdomyosarcoma. It's a transcriptional factor of muscles. So we do a FISH for this region of chromosome 22 that was rearranged. That's typical of Ewing sarcoma in some cells, and in other cells we have PAX3 rearrangement that's typical from rhabdomyosarcoma. So the mass have two kind of cells, and we could have the final diagnosis integrating FISH, flow cytometry, and also the histopathology and immunohistochemistry. So in the first paper, we have described the markers that were expressed in each kind of tumor. I put more or less in red the ones that most differentiate the tumors. So CD99, CD271, that's high expression in all sarcomas. And GD2, that's expressed in neuroblastoma at that time. So we decided to develop one single combination to screening diagnosis of tumor cells in pediatric samples, and also to characterize the immune cells infiltrating the tumor. In the first paper, we have this combination. After 2013, we passed to use this one to start the screening. And we have a panel of characterization that in the principle, we don't have many antibodies. We don't have conjugated one with fluorochromes. After they appears in the market, so we could use more antibodies conjugated with fluorochromes. And the limitant step was the number of cells, because we have, we have more samples in the first phase than in the second phase, because some samples we don't have cells to continue to study, to perform all tools. So it was another reason to have one strong antibody combination to use in the first screening. So we have merged all these old files, and we have performed a principal component analysis. With here we have several files of several patients together. So we put Ewing sarcoma in light blue, rhabdomyosarcoma in dark blue, and neuroblastoma in red, Hume's tumor in green. So we have performed principal component analysis comparing each pair of disease. And we have observed the weight of this principal component analysis, linear combination of parameters. that it's not supervised method that attributes weight for each parameter to achieve the maximum variance among the events studied. So the markers that received more weight were CD271, GD2, EPCAN to discriminate Wilms tumor, CD99 for Ewing sarcoma. So we designed this antibody combination with a kind of backbone markers to identify tumor cells, CD45 negative, CD56 positive, and principal markers to identify the most frequent tumors in pediatrics, GD2, EPCAN, CD99, CD271, and myodenine. And also we put there CD3 in two colors, CD3 in membrane, in APC87, and CD3 in cytoplasm, in BV421, to identify, for instance, lymphoblastic T lymphomas that can express, most of them express the CD3 in cytoplasm without CD3 in membrane. And we also identified T cells infiltrating the tumor. I have CD19 to identify B cells and also B cells lymphomas. And CD4 and CD8 to discriminate among T cells, each subpopulation. And also with CD56 positive and 45 positive, we can identify also NK cells. So here we have in lymphocytes gate, we have T cells with expression of CD3 in both channels. We have B cells in CD19 with CD19 expression, and NK cells with CD56 expression, dim or bright. And here we have in the T cells gate each subpopulation of T cell. In myeloid cells gate, we can identify monocytes, neutrophils, and eosinophils by scatter, by CD45 expression, and also by CD4, because monocytes expression CD4. And the tumors. Here we have a peripheral blood sample with such cells, 45 negative and 56 positive. We can see that very few cells can be identified in peripheral blood. With GD2 expression, was a neuroblastoma in peripheral blood, negative for the other tumor antigens. Here we have a tissue, a mass tumor, infiltrated by Ewing sarcoma, also with CD56 high, without myodenine, with CD271 high expressed, GD2 heterogeneous, most cells negative, but some cells low positive. It's typical of this tumor, and CD99 positive. And here we have a bone marrow sample. Here we have the erythroid cells, nucleated erythroid cells in dark red, and tumor cells in blue, with high expression of CD56, with expression of myodenine, 271, negative for GD2, and negative for CD99. And it's a Wilms tumor that expressed also EPCAM. CD271 is positive, but not in this figure. And here we have also identified stromal cells from kidney. We have samples of non-infiltrated border of tumor. So we could characterize kidney cells, normal kidney cells, and compare them to tumor cells. It was nice for us. And in that time, two years ago, more or less, we have identified debris and doublets just with backgating. We performed viability studies with PI, but it's not useful for us because it occupies many fluorescence channels. So we decided to don't use viability marker, but it was could be nice to have a good viability marker because the tumor mass have many times more depth than bone marrow and peripheral blood. Many times we cannot process the sample immediately because the surgery timeout was 11 o'clock at night, so we have to do early morning and another day. So we tested the FVS 780. It's a new dye for viability, and it stains very high, and we can use it with the markers. I have to change this picture for one picture with lymphocytes here, because in this channel we have CD3 and CD19, and they stain it here, and deaf cells almost outside of the graph. So we can properly separate the non-viable cells in an easy way. So now we are using routinely this marker. So we add on top of the other markers here. And this is more or less a resume of the markers expressed in each tumor. Neuroblastoma tumors are positive to GD2 and 56 in most of them. Ewing sarcoma, CD99, CD271, CD56, rhabdomyosarcoma myodenine, and CD271. Osteosarcoma was just positive to CD271, 56, and also 56. Wilms tumor is positive to EPCAM, CD271 and 56. And clear cell sarcoma, that's another kind of kidney tumor. And it expressed GD2 together EPCAM and CD271. germ cells tumor are a family of entities that we could not characterize properly. We can identify in most of samples non-hematopoietic tumor cells, but we cannot say it's a germ cell tumor because they are very variable, not only in the markers that we put in this combination, but also in other markers we are studying. It's a little bit a next point to address. And the carcinomas are positive to EPCAM, negative to CD271, and we can, with this combination, discriminate this kind of tumors. Here is the complete list of tumors studied. And now we have many more samples done in the paper. I don't know. More or less 500, and now we have 800 because after the paper, finally we have our samples from INCA. And we have also put this antibody combination in an international study in 7 countries. So we are receiving not the samples, but the files stained from several labs. So we are accumulating fast samples. Now we have more than 800 samples. We have excluded samples that are not comparable to histopathology, and we have put in this analysis 631 samples, and we have an agreement of 91%. A high sensitivity also, 94%, and 100% of specificity. So in patients when the sample is not infiltrated, we never say that they are sick. It's nice. In reactive samples also, we never say that they have tumor when they don't have. And the others, these are the patients with tumors. We achieved the final World Health Organization classification of the tumor, the final diagnosis, in 242 plus 5. These 5 samples, the pathologist said they are disease-free, but we could prove by other techniques that they are in fact infiltrated. Some of them we sorted cells and do the fish in sorted cells. These 5 samples were samples with very low infiltration. Most of them bone marrows with very low infiltration. And we have a kind of intermediated diagnosis. So in 60 samples, we said there is a non-hematopoietic tumor. It's correct, but it's not the final classification. But maybe it's useful to start a treatment in kind of urgency or so on. And in 27 samples, we failed the diagnosis. So most of these samples were neuroblastoma, rhabdomyosarcoma, Wilms tumor, Ewing sarcoma, and non-Hodgkin lymphomas. That's more or less logical with the markers we have selected. Here we have rare pediatric solid tumors that never been described by flow. So we have 1, 2, 3 samples that we have described the immunophenotype, but we don't know if it's a solid pattern of expression. So we have to follow the study to accumulate more samples from this kind of tumors. Here we have germ cells tumor, I think 25 samples, and each one is a little bit different of the other. It's difficult to establish a pattern. And samples with low cellularity here and here. Here, samples with low cellularity, low viability, more than the cellularity, low viability of the sample. And more or less half of this failed diagnosis are Hodgkin lymphoma. So we started a new study in 2021 to design a new tube to identify Hodgkin lymphoma cells. Now we have some more or less nice, but few samples yet. And we can use also, besides to diagnose, we can use to identify circulating tumor cells in peripheral blood and metastatic tumor cells in bone marrow or in other tissues. So in future, we can think about a non-invasive diagnosis if it will be consistent. And we can also monitoring the profile of immune cells in tumor and observe difference of such cells in each kind of tumor. For instance, rhabdomyosarcoma and Wilms sarcoma have more monocytes and dendritic cells, and T cells are higher in Ewing sarcoma and neuroblastoma, and the ratio CD4, CD8 is higher in germ cell tumors. So we are accumulating this data and preparing a new manuscript now. And we can also, it's a potential use, we can also orientate immunotherapies. For instance, GD2 is antigen, there is an antibody anti-GD2 for clinical use that is useful in neuroblastoma and retinoblastoma. And we can describe the expression of the intensity of expression of GD2, maybe to help such indication. And also there are CAR T cells anti-GD2 now. So less used than this antibody, but it's another potential use to indicate and also to follow cells after this treatment. And we are also building a database with tumor cell case to prepare a kind of automated analysis as a support decision, support clinical decision, as we have done to acute leukemias. So several groups in the world involved with our study, and several groups of students that were involved also. Christiane is a pediatric oncologist that worked with me since the beginning. She was my master student, my PhD student, and now she's a PI leader with me of this study. And now are in the lab these four, and Enrico is a PhD student, and these are our IC students. Amanda is a master student. And the staff of the lab, we have 4 biomedical and pharmaceutics working in diagnostic field there. So, thank you.
Thank you. Thank you very much, Elaine. So, podia ter pego. Okay. So thank you very much for the talk. We usually ask the students if they have any questions first, and then we go for the professors. Lucas, do you have anything? Okay. So.
Hi, thank you for your talk. I'm also a lover of flow cytometry, so for me it's always nice to see it being used aside from basic research. I was wondering whether have you considered also using exhaustion markers like PD-1, maybe as an associate marker for disease severity, or also to indicate whether treatments should involve or not anti-exhaustion marker antibodies or whatever?
So we have also think about it, but I think we need more channels to use. So we are expecting to buy a Aurora cytometer to perform such investigation. But it's a spectral cytometer with 35 channels. So a Faxcanto 2.
Gustavo, Diego, se tiver alguém, if there's anybody with a question on that end, if you could raise the hand, then makes it easier for me to identify here in the list. So I'll take the chance to ask another question. Elaine, when I wonder about the stemness markers that you use. Do you see post-treatment any type of correlation on depending if you have more of those cells showing up in the beginning when you're screening and the response to treatment, or eventually are you able to follow those patients later in life and see if you have recurrence and if there is any correlation with the data that you get on this first those first tests?
Yes, we are following these patients, but it's difficult because they are in many different centers. So it's not easy to recover clinical information in all the centers, but now we have Gabriel is a medical student that he is going in the hospitals and note the clinical information and so on. And I think it will be better now.
Thank you, Bruno.
Thank you for your talk. It's very nice. It's very, very interesting. I was really surprised on how long it takes to get diagnosis with the traditional techniques. And why does it take so long? And is it because these services are really overwhelmed? It's just because it's all the steps that it take for you to get the diagnostics, and why can you actually put these in a large hospital routine to get these diagnoses by flow cytometry, or it works because it's you doing it, and you're very good on what you do?
So now we are thinking that it's possible to put it in more hospitals because it's running in 7 hospitals in Europe. And in Brazil, we started in Brasilia, in Children's Hospital from Brasilia. And the stains are very well done, and the analysis. So I'm yes.
The turnaround time is like in hours.
In hours, yes.
And what's up? Is there something that's
But
can be improved?
the pathology, I'm surprised because I always think that it's because we are in public health, we are in if so on, and recently I have a friend with a tumor suspicion, and I was talking with the pathologist, and it takes 1 month. It's an adult tumor. It was not an easy tumor because he doesn't have a primary site. So at the end, it was appendix origin. It was difficult, but 1 month to take the stains and the conclusions in a very good private pathology lab with, I think, the best pathology I know in Rio, Sergio Romano, that was from Inca 30 years. He's a very nice guy. But it takes time, including outside the public health.
Yeah, and that's actually my my question. These difference in speed for the diagnosis, does it actually affect the outcome of the patient? Do you have this study already? Well, it will be a point of analysis for later on to know if doing it faster, it actually improves the outcome of these patients.
We don't do this study, but during our study, I can remember some situations that I had one PhD student that he defended the thesis. I remember, I think 18 of October. So in that day we had rhabdomyosarcoma. We do the diagnosis in crazy mode because the thesis and so on. And I report in the same day, so I forget the story, the case. In my birthday, in 5 of November, I hear that the girl that's without the diagnosis. No, it's impossible because I provide the diagnosis. So, but the hospital from origin waited for the pathology, and the girl died before the diagnosis. I don't know how many. We have to do it. We have to describe it. Now we are until the last paper, we performed the diagnosis in blind way because the study. But after this second publication, we are calling for the pathologists, and we are talking with them. We have to stand to DD2, have to stand to so on. So they changed the order of markers. So
that's another thing. That's
we
they
can
help instruct how the pathology lab will actually work to confirm your diagnosis, and not to screen everything.
Yes.
They have some idea about what to look for, and just that's the right tumor. That's how we should proceed then eventually.
Yes, we have to documentate the. We have this in a database, the date of diagnosis in our lab. The data is to do the counts.
Are there any questions on that end? We are looking here, there are no hands raised. I'm not sure if there are any more questions over here. I think it's beautiful to see your data, Elaine, because you do put in context this thing about being on the bedside, right? Is really applicable. And what you mentioned, sometimes we do need to do those tests, the blind tests. But as soon as that part is over, it's much more efficient if you can already direct the pathologist towards spending less resources and being more expedite, because you're already defining which tests need to be made. So it's really beautiful and interesting how it will develop further on. And it's nice also that you'll be able to get the data and analyze from different centers, because then I think here it is so you are the reference for pediatric tumors in Rio, in the state of Rio, right? And it's national as well, or?
Yes.
It is, right? Yeah, so it's really beautiful, the work that you're doing. Thank you. So Gustavo, Diego, do you have anything from that end? I'm not seeing here, but
I think we don't have any questions from students here now.
okay. So do we have any more? So I'll thank you very, very, very much, Elaine, for accepting our invitation. And I remind everybody that next Monday is a holiday. Here in Rio, in São Paulo, and a few other cities is on a national holiday. But since both cities are on holiday, then we are going to skip, and then we come back with the WISP being the host. So thank you all very much, and I'll see you in a couple weeks. Tchau, tchau, pessoal. Obrigada.
Tchau, tchau, até mais.